everybody, my name is Palatin Shaaker, and today I'll be presenting my research on equity-driven therapeutic strategies for colorectal cancer in marginalized communities. So a little bit about me is that I'm a rising senior in Thomas Jefferson High School for Science and Technology in Alexandria, Virginia. I'm an African American and youth ambassador for the International Kindness Sharing Organization, so I love to volunteer my time with Afghan women by conducting fundraisers and tutoring women in Kabul. And I've also conducted research under Harvard Medical School and Johns Hopkins University School of Medicine professors. In the future, I hope to be the first doctor in my family and learn more about public health to serve marginalized communities through equity-driven care. So to begin, my passion for research really stems from my experiences that I've had with my community. My grandmother was born in Mazar-Sharif, Afghanistan, and was the first woman in our family to finish primary school and graduate from high school. When I was very young, she was unfortunately diagnosed with late-stage colorectal cancer. After her passing, I want to understand more about the inequities faced by marginalized communities when it comes to cancer care. That led me to work with women living in displaced persons camps in Afghanistan, who are not only fighting cancer, but also navigating serious gaps in access to treatment and resources. As a youth ambassador for the International Kindness Sharing Organization, I directly communicated with women in internal displacement camps in Afghanistan to better their healthcare situations. Many women were diagnosed with cancer in the late stages since access to early detection modalities is very difficult due to the restrictions placed by the Taliban in gaining access to these facilities. In addition, in advanced stages similar to my grandmother's, current traditional therapies, including chemotherapy and radiation therapy, lead to a number of harmful side effects, further decreasing patients' overall quality of life. So my independent research was conducted at the Johns Hopkins University School of Medicine and was focused on colorectal cancer. As the third leading cause of cancer deaths, colorectal cancer has few current therapeutic solutions due to its multi-stage and multi-step progression nature, and will also lead to 1.6 million deaths per year globally by 2040. So in my research, I focused on microsatellite instability high, or MSIH cancer, which is a common subtype of this cancer. This subtype is characterized by high mutation rates due to a blockage of MMR genes, and therefore it is incredibly difficult to treat compared to other cancer forms, since this cancer evolves very quickly and develops resistance against traditional treatments. There is a large disparity in cancer care as well, but particularly in colorectal cancer care, which is evident since there's a 40% higher mortality rate for African Americans as compared to non-Hispanic white individuals. This is likely due to the fact that colorectal cancer polyps are asymptomatic, so many underserved communities may experience a delayed diagnosis. Effective treatment solutions are also yet to be found for MSI colorectal cancer, in particular due to rapid mutation rates. Traditional treatment methods, including chemotherapy and radiation therapy, as I previously mentioned, have a large number of side effects. And traditional cancer treatments may not be equally effective for all patients. So for instance, individuals of African ancestry face disparities in the success of current therapies. So when tumors of African American individuals were sequenced, there was a 30% less likely chance that they could exhibit mutations that would make them ideal candidates for immunotherapy, highlighting a significant gap in treatment equity. The field of targeted therapies is incredibly new and rapidly developing, and it has shown significant promise since targeted therapies specifically inhibit certain cellular mechanisms, so only cancerous cells are affected by these therapies, and thus there's less harm to a patient's overall well-being. Many can also be administered orally, making them more accessible outside of major medical centers. Dual targeting therapies are especially promising for hard-to-treat cancer since they specifically inhibit multiple cellular mechanisms, and there's an overall higher chance of overcoming drug resistance mechanisms from these hard-to-treat cancers, such as MSIH cancer. In my research, I specifically worked with two small molecules in particular. They're called BMH21 and HR761, which are novel inhibitor molecules in the field specific to MSI cancers. So as you can see on this slide, HR761 works by inhibiting the Werner helicase protein. The Werner protein typically religates and fixes DNA strands when broken, so this inhibition increases DNA damage levels. On the other hand, BMH21 works by inhibiting the RPA194 subunit, which is part of RNA polymerase I. RNA pol 1 directly creates rRNA, and since rRNA creates protein, this inhibition overall decreases protein levels. My research is especially important since these are very novel small molecules against MSI cancers, so this is really the first study investigating the therapeutic efficacy of this specific dual targeting strategy of using these drugs in conjunction. So my overall hypothesis, as you can see here, is if BMH21 and HR761 drug therapies are used in conjunction on the HCT116 MSI colorectal cancer cell line, then it will result in significantly higher reduction in cell viability as compared to the use of either drug alone. So to begin with my experimentation, I used a cell titer blue assay and then used the gold standard computational method in the field, which is called the Bliss Independence Dose Response Surface Model, to find the characterization of this therapeutic strategy. If you take a look at this dose response matrix it outputs, there's a significant additive effect, meaning that the combined effect is around the sum of each of the drugs alone, as you can see in the table in the top right of the slide. While the Bliss model characterized it as slightly antagonistic with a synergy score of negative 4.77, that was primarily because I used incredibly high concentrations of these drugs. So I conducted additional research and looked at the results more holistically. So for example, according to this table, there was a double in inhibition rates when using the drugs in conjunction, and after communicating with scientists and professors in my department at Johns Hopkins, I decided that this is an additive effect based on the extensive supporting data as shown in these figures. I also used further experimentation to understand the molecular interactions behind this therapy. I used an immunofluorescence assay to better understand the DNA damage. So if you take a look at the panel figure in the bottom, DAPI is a marker that illustrates where cells are located, and gamma H2AX illustrates where DNA damage occurs, and as you can see, this color glows brighter once we get to the combination therapy, demonstrating an increase in DNA damage with this dual targeting therapy. In addition, the flow cytometry assay, which is in the top figure, illustrates an increase in G2M and SV cell cycle arrest, likely because of replication stress and thus an increase in activity for immune checkpoint molecules that inhibit cell growth. So in conclusion, my research illustrates an additive effect in this combination therapy with double the inhibition efficacy as compared to the use of either drug alone once combined. There's also greatly increased G2M and SV cell cycle arrest in this therapeutic strategy, meaning that there's an increase in replication stress and apoptosis. This provides the preliminary results for using this multi-targeting therapeutic strategy in other contexts, such as in clinical or in vivo use in the future. So one of the most valuable things I learned through my research is that truly novel ideas in science, and especially medicine, emerge when we think equitably, considering a wide range of experiences and backgrounds. Innovation does not happen in isolation, but happens when diverse perspectives inform both the questions we ask and the solutions that we pursue. So that's why I'm really drawn to targeted therapies, because not only are they a cutting edge form of treatment, but they can also be administered orally, making them more accessible outside of medical centers. From my experience with my community, I understand that this should be a significant priority. So from my work with Afghan women, I've seen firsthand how critical it is for marginalized communities from rural areas in the US to underserved regions globally to have access to treatments that doesn't depend on proximity to hospitals or specialized care. Equity is not just a value, but a scientific necessity if we want our discoveries to truly help everyone. And we can expand equity through using BIPOC cancer models or pursuing research while collaborating with members of marginalized communities. Thus, it is important to remember that research is not merely science, but an all-encompassing tool for justice. And by considering innovative therapeutic solutions for diseases with high disparity rates, such as MSIH colorectal cancer, we can ensure that our cells, like our stories, are seen, and we can contribute to a more ethical and equitable world. Here are my references. I want to thank the Johns Hopkins University School of Medicine and the Afghan women who have been brave enough to share their stories with me and inspire my love of research. Thank you so much for listening to my presentation. Here's my contact information. Do you have any other questions?